Okay, so problems with these, and surely we can do better. So, 2 years ago, melanoma finally made the front page of the New England Journal, which is sort of in medicine, that's kind of the mecca, or the big announcements in any medical development come into the New England Journal. And within a year we had some major headlines with respect to progress in melanoma. Okay, so the first thing I'm going to talk about is this targeted therapy. So just to give a little background behind this, I've told you before that there were 4 kinds of melanoma that we kind of typically described. And what some investigators did is they looked at these 4 types, but looked at sort of their molecular makeup to see what distinguishes them more than just how they appear to the eye, but on a molecular level, were they different? And they had lots of clues in terms of what kind of genes may be altered in these types of tumors. And they were able to identify some differing genetic signatures for each of these types of melanoma, which was quite intriguing. So not only did they look different, but now we could see that their molecular signature was different. And this kind of describes some of the differences. So the non-CSD is the non-chronic sun exposure disease. So these are the ones, the melanomas, and typically are the superficial nodulars, which develop in skin that hasn't had a lot of exposure to sun. So they may have had lots of sunburns, but they don't have chronic sun damage. And you can see, compared to melanomas that developed in patients who had chronic sun exposure, for example, those lentigo maligna on the face, or often we see on the hands in patients, the molecular signature, the composition of these particular genetic alterations was very, very different. Then they looked at the acral melanomas, and those are the ones on the hands and feet. And once again, the molecular signature is really very different. And then the mucosal are the ones are quite rare, but these are melanomas that develop in the mouth or the gastrointestinal tract, and are again very rare, and yet they behave very, very aggressively and very differently than the skin primaries. In doing this, they identified one in particular that this BRAF mutation was present, most common in the non-chronic sun-exposed patients, and the acral a little bit more so, but not so much in the chronic sun-damaged skin. So it indicates that this BRAF was mutated more commonly in this type of melanoma. And if it wasn't present, and it wasn't present as often in some of these other types of melanoma. Okay, so what is this BRAF mutation? Well, this is an acquired mutation in the internal machinery of the cell, which basically causes the cell to proliferate in an uncontrolled manner. And we can look at all kinds of different malignant tumors, and this particular genetic abnormality can be identified in a lot of different cancers, not just melanoma. But it just so happens in malignant melanoma is that this is about 50% of these have this particular abnormality present. So if the normal RAF is replaced by this BRAF V600E so-called mutation, when that is present, it basically puts on the gas and drives the cell to proliferate. So one of the hallmarks of cancer cells is their uncontrolled proliferation. And this, in certain tumors, this acquired mutation, keeps driving the cells to proliferate, and that's why they keep growing. And this was present in 50% of melanomas. And as I indicated to you, of those, there's more common in those patients who didn't have chronic sun exposure, or who had the acral litiginous type of melanoma. That mutation was present. And then RG7204 was a drug that, because they know where the abnormality was, if you could somehow turn off that gene, maybe you can stop this uncontrolled proliferation. And so they basically designed a drug which inhibits the ability of BRAF to translate the message of cellular proliferation down the subsequent cascade. So it blocks this mutation from giving its abnormal signal. So this particular drug, which is now known as Vemurafenib, also hit the New England Journal it was sort of the first of the wave of the good news story. And they were doing some testing looking at this drug and its activity. And when a new drug is developed, the first question is, can humans tolerate it? Does it have side effects? And that's probably the first thing we have to ask, is it safe to use in humans? And of course, does it have some particular activity? And so this was a study that was done on really not that many patients, but the results were dramatic. So much so that a very small study and a preliminary study made it itself into the New England Journal. And the big news is basically demonstrated in this what we call waterfall plot. And each column represents a particular patient. And it shows the change in their tumor after receiving the drug. And so most you'll see are negative changes, so this is percentage change. So that if the tumor completely disappears, it's 100% change, so it's disappeared. If the tumor grows on the drug, then it's positive. So you want to be below the line. And if it's more than 50%, we say that's a partial response. And if it's all the way down to 100, then it's a complete response. So this shows that virtually everybody who got this drug had significant tumor shrinkage, including the people who had it completely disappeared. Now in melanoma, we just rarely see this. I told you the IL-2, occasionally we get this complete response, but most of them don't have anything close to this kind of appearance. And this was remarkable because it was an oral agent in these patients who had this mutation, and the effect was striking.